The background to this study is that Black men are at least twice as likely as white men to develop prostate cancer and therefore to die of prostate cancer. And for many years, there has been this almost nihilistic view that the tumor biology is more aggressive and the outcomes are naturally worse. But the caveat to that is that most of these studies comparing Black and white men were conducted in the localized prostate cancer setting and almost exclusively in the United States. So for the first time in the European continent, our hospital, Barts Health NHS Trust, one of the largest trusts in the country, conducted a retrospective analysis of outcomes of Black men versus white men in the setting of metastatic castration-resistant prostate cancer, and found that, if anything, Black patients with MCRPC did at least as well, if not better, than their white counterparts. In our retrospective analysis of 425 patients, we found that the overall survival of Black men was 25.5 months versus 21.8 months in white men. So that constitutes a hazard ratio of 0.81 favoring the Black population. And perhaps more strikingly, if we looked at the subset of patients, about a quarter of patients who never received chemotherapy during their treatment regimen, be it for personal choices or medical reasons, the Black men actually did a lot better. In that subset of patients, the median overall survival was 39.7 months in the Black population and 17.1 months in the white population, with a hazard ratio of 0.54 favoring the Black population. Why do I think this study is important? Black patients are obviously disproportionately affected with prostate cancer, and we don't quite know the reasons why. But what this paper serves to show that is that in an equal access healthcare setting, and when we engage the community sufficiently, Black patients, if diagnosed at the appropriate stage and treated appropriately, can develop even better outcomes than their white counterparts. That's a very good question, and in fact a question that was highlighted when I presented the findings in GU ASCO in San Francisco a year ago. So this is an equal access healthcare system, and in a way the first time it's been conducted in a nationalized healthcare system like the NHS. Most of the studies done previously were performed in the United States, and whilst they have a wealth of databases, lots of confounding factors arose, such as social economic disparity and unequal access to healthcare. I think what people should take from the study is that healthcare access and empowerment of the patient population are both very important, making sure that they're aware of the risk of developing prostate cancer, particularly if their risks are higher, such as in Black men, to approach the relevant healthcare professionals. And for the healthcare professionals to realize that, whilst Black patients are probably more likely to develop prostate cancer if treated appropriately, they can develop better outcomes. The second thing to take home from this is, what are actually the key messages of this paper and how do we take this forwards? The first and probably most important point is representation in both the workforce and the clinical trials. In the United States particularly, the Black population constitutes something in the order of 15% of the community, but represents only about 2% of the urology and oncology workforce. So that's an underrepresentation. So that's quite key. Having underrepresented ethnic minorities such as the Black population in the medical force is important. Secondly, representation in clinical trials. There was a study showing that Black men, despite being more frequently diagnosed with prostate cancer, were significantly underrepresented in all the pivotal clinical trials to date. They are up to 7 times less likely to be represented in clinical trials of prostate cancer, considering the incidence of cancer in this population. So making sure that they are reflected in the results are very important. What not to take from this study? There are confounding factors. This is a large single-center retrospective study. And despite this being for 425 patients, it has to be taken with a pinch of salt that this was performed over 20 years with some variability in treatment. And secondly, to be able to generalize this to both the UK and US population with vastly different healthcare systems, we have to be a little bit cautious about that as well. But what we must start to do as an oncology and uro-oncology community is partake in discussions with our friends across the ocean and in fact across the world to mitigate these disparities. So I think this is a start, and much more exciting collaborations and discussions to be had.